Hello, everyone. Thank you so much for joining us on your lunch break for our first Talk with HIROC live stream of the year. I'm Mark Aiello, Communications and Marketing Specialist at HIROC, and today I'm fortunate to be joined by my colleague Enid Sue and our special guest. In a moment, Enid will introduce our guests who are here today to chat with us about drug diversion in healthcare and to raise awareness of a new tool available now that will help organizations address this very important issue. But before we begin, I'd like to acknowledge our Indigenous peoples and the lands we're speaking from today. Enid and I are speaking from Toronto, the traditional territory of the Anishinaabe, including the Mississaugas of New Credit, the Haudenosaunee, and the Wendat. Today, this gathering place is home to many Indigenous people from across Turtle Island, and we at HIROC are grateful to work on this land. While we are meeting on a virtual platform, I would like to take a moment to acknowledge the importance of the lands we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and improving our own understanding of local Indigenous peoples and their cultures. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. Now, for a couple of reminders, please keep privacy and confidentiality in mind if you're interested in posting a question or comment in our comment section. We'll be doing a Q&A session at the end of the talk, so feel free to post something at any time, but we just ask that you keep privacy and confidentiality in mind as you do so. I'll be keeping track of all the questions that come in, and we'll show it to our panel at the end. Another reminder is that any of the resources or contact information discussed today by our panel will have a link to them posted in our comment section, so be sure to keep an eye out for those links. And that's all for me. Take it away, Enid.
Thank you so much, Mark. Hello, everyone, and happy February. I'm Enid Sue, Senior Healthcare Risk Management Specialist at HIROC. It is my pleasure today to be with our panelists to talk about a risk that not only impacts safety of our patients, but also our colleagues, healthcare organizations, as well as the healthcare system as a whole. Drug diversion, more specifically controlled substance diversion, is a subject of safety concern that is not often talked about. Today, we're privileged to be joined by three expert system leaders who will be chatting with us on this very important topic. So we have Patricia Trbovich, Bateau Family's Research Chair in Patient Safety and Quality Improvement at Northrop General Hospital. We also have Mark Fan, Research Manager from Northrop General Hospital, as well as Dr. Michael Hamilton, Medical Director at Institute for Safe Medication Practices Canada, ISMP Canada. So Patricia, why don't we start with you? Thank you so much for sitting down with us today. What prompted the team's interest in exploring the complicated issue of controlled substance diversion, and why is it so important?
So thank you for this opportunity. It's our great pleasure to be spending some time talking about drug diversion. So what got us interested in the topic? Well, my team had been working with the Institute for Safe Medication Practices Canada for several years on applying a human factors lens to medication safety. So when the Institute for Safe Medication Practices Canada approached us about this topic of drug diversion, we were intrigued. I must admit, I wasn't sure what the term diversion referred to when I first heard it. So in case others are not familiar with the term, it refers to theft of medications, either for personal substance use or for trafficking. So essentially it's when controlled substances such as opioids get transferred from legitimate medical use to non-medical use. And it has huge patient safety implications because sometimes it can mean that a patient doesn't receive the pain medication that was initially intended for them, for example. So we started looking into this topic and we quickly realized that it was understudied. Certainly from a research perspective, there hadn't been much work done on understanding opioid diversion in Canada. And we also noticed that when people did touch on this topic, they tended to focus on it from an individual rather than a system perspective. And so we saw parallels for where we were about 20 years ago with the patient safety movement when we were looking at preventable adverse events. Healthcare institution often viewed it as a person problem. So they often saw people as the source of error and blamed and shamed them for the errors that were happening. And so we saw a similar tendency when it came to drug diversion, and we really wanted to take more of a systems perspective. Obviously, there's always some personal accountability to these types of topics, but From a human factors perspective, we were really interested in understanding how did our systems fail to, in this case, detect or avert diversion. And so I just really want to highlight that the purpose of our project wasn't to go around, it wasn't a witch hunt to find who is diverting in different healthcare organizations, but rather it was really to look at how are our systems configured, and what are some of the system factors that might be allowing for diversion to occur or preventing us from detecting when it does occur. And when I talk about system, I'm talking about things like how our tools are designed. It can be something like how our ordering systems are designed, can allow for falsification of orders, or how our drug dispensing cabinets get configured can have an impact on whether we can detect whether the proper medication got retrieved and whether it reached the proper patient. Other times we might be talking about task-related factors. So it's very common that when you're administering a controlled substance, there's an excess after you've delivered it to the patient. That excess should be wasted. So we were interested in looking at what are the processes that have been put in place to ensure that the wasting actually occurs. Other times it might be more of an environmental factor, such as like when you're moving a medication from one unit to the next. Do we have the proper controls in place to ensure that these controlled substances are not left out in the open? So these are just a few examples of the many system factors that contribute to diversion. So the purpose of our project was really to identify these different system factors so that when we identify interventions, we can align them to those different factors. And you asked why. Why is it important? So I touched briefly on the fact that it has patient safety impacts, but the impacts are much broader. So in fact, it actually touches on all 4 elements of the Institute for Healthcare Improvement's quadruple aim of healthcare improvement. So patient impacts. Sometimes the patient don't receive the proper anesthesia. It might be that they're receiving care from an impaired provider. We've seen patients who have been contracted an infection from a compromised syringe. It also has healthcare worker safety implications. So healthcare workers who are struggling with addiction, if they don't get the proper support, they could be facing lawsuits and litigation. We've also seen healthcare providers who have overdosed and led to their death. It has cost implications. So healthcare institutions are obviously suffering from the loss of the opioids or other controlled substances that get diverted. But the cost implications are also in terms of how much it costs to do an investigation, the reputation damages. In 2018, there were several hospitals in the US that were fined excess of $4 million because they were found to not have the proper safeguards in place to prevent diversion. So it certainly has cost implications. And then also population health. Like we know that controlled substances that are being diverted from our healthcare institutions can find their way into the street and lead to trafficking. And it's certainly not a causal relationship, but we have seen that as the opioid crisis has increased, we've seen an increase also in the rate of opioids that get diverted from our Canadian hospitals. And I emphasize that it's not necessarily a causal factor. The reason that we might see an increase in the amount of opioids that are getting diverted from Canadian hospitals might be a reflection of the fact that we're doing a better job of detecting them. But regardless of the reason, we are seeing an increase over the years. So it has huge impacts, and I'll let Mark and Mike talk more about our research in this area, but I'll just highlight that we started off by doing a scoping review to really understand what do we know about this topic, and then we also looked at databases, including Health Canada, to understand the prevalence of drug diversion across Canadian hospitals. And then we also conducted direct observations in different hospitals and different units to really understand in detail what are the different system factors in terms of how we manage controlled substances in our healthcare institutions. And then when we started presenting our findings, we saw that a lot of healthcare organizations were interested. It really resonated with them. So we applied for a grant to CIHR, the Canadian Institute for Health Research, and we were successful in receiving a multi-year grant, which allowed us to translate our findings into a risk assessment tool that hospitals can now use to identify where in their system do they have a vulnerability related to diversion. And we also created a quick reference guide so that once they identify a specific vulnerability, they can look up various interventions that are known to help prevent those vulnerabilities. So I'll stop there and let Mark and Mike talk a little bit more about the research.
Yeah, thank you so much, Patricia, for sharing with us the background of such impactful work on a very serious topic here. So, Mark, as a researcher and a human factor expert, why don't you tell us a bit more about the risk assessment tool, the evidence behind it, and the structure of it?
Sure. Well, thanks, Enid. Maybe I'll start with some of the evidence that we use to build the risk assessment tool. And there's two categories. So the first is published literature, and Patricia had mentioned the scoping review that we did. And we cast a pretty wide net with that search. So we looked not only at formal peer-reviewed research articles, but also gray literature. So that includes news articles, trade magazines, conference presentations, editorials, that sort of thing. And the reason we did that is that there's a lot of excellent information that's shared by frontline managers or operational staff that are addressing diversion in hospitals. So they can share specific details about what happened in their institution and what their plans are to mitigate them. So that's category one, which is the literature. And then we also, as a team, did our own observations in Ontario hospitals. And so that was led by a PhD student, Micah DeVries, who is now graduated. So congratulations, Micah. And same idea. We went into the medication use process and looked at each task that had to happen and tried to figure out what are the vulnerabilities associated with each task. So basically, you could figure out that there were two main risk factors that came out of the literature search and the observations. The first being the physical security of controlled substances. So they can't stay in a locked cabinet forever. You do have to take them out, transfer them between clinical areas, administer them, and waste them. And so in those moments, they're not supervised as well, and they become vulnerable to just being pocketed or diluted, or maybe substituting another medication in their place to obscure that diversion has happened. So that's the physical security. And then the second piece is the accuracy of documentation. So there are a variety of ways to falsify documentation. You can forge signatures. Depending on how your computer systems are set up, you might be able to use someone else's login and password so that transactions that you do are actually attributed to someone else. And you could just write numbers higher or lower than what's the actual reality is, so that when people try to trace the pathway of the medication, it becomes very difficult to understand where the discrepancies emerge. So thinking of physical security and documentation through every stage of the medication use process is not a trivial exercise. It does take some work. And that was the idea behind the risk assessment tool. So Mike will talk a little bit more about registration, but when you register for the tool and you log in, you'll go through a series of risk assessment questionnaire items, essentially. And the first screen, I'll just tell you some of the sections. The first screen is demographics. So that actually is very helpful for two reasons. One, for us as researchers, we can see if there are differences in the types of risks that different hospitals experience. So maybe a hospital with an electronic automated dispensing cabinet will have different risks than ones that are using a paper-based system, or a larger hospital versus a smaller hospital. And also those demographics will help with hospitals benchmarking their risk scores with each other. Then after the demographics, there's a hospital-wide safeguards section. And an example of an item there would be, do you have a dedicated committee of staff who are looking at unresolved discrepancies, pulling data reports, investigating potential diversion? You really need some dedicated people on that. And then we ask some questions about the entry point of medications into the hospital. So who's ordering it? Who's double checking that those orders are appropriate? Or when they're actually received at the hospital, who's verifying that that's what you ordered? Or what if patients bring their own medications? So if a patient comes with their own narcotics, are we securing and documenting that appropriately? Then once the medications are in, there's sometimes repackaging or compounding in the inpatient pharmacy. So you might imagine that like a bulk container of hundreds of opioid tablets are being repackaged into unit doses. There's quite a bit of medication there that's vulnerable to diversion. So we have some items associated with that. Then there's the transfer of those medications out to the clinical areas. And then of course the activities in those areas themselves. So withdrawing from the unit stock, administering, and wastage. So there was actually a lot we wanted to put in the tool, probably too much. But thankfully, we partnered with the Canadian Society of Hospital Pharmacists Ontario branch, and they put together a wonderful panel of pharmacists that actually kind of went with us step by step through the risk assessment tool and figured out which items are most essential to keep so that we could have a comprehensive review without being too long. And I'll just thank Samantha Yao, who was the president of CSHP Ontario branch at the time, who spent many hours with us just clarifying the language and making sure it was accessible. So I'll stop there and pass it back to you.
Wow, thank you so much, Mark. It's really incredible to hear the dedication that the team have put into the development of the tool and all the considerations that's been put into it. So, Michael, as the medical director at ISMP Canada, can you tell us a bit more about the process as to how a facility can sign up for the risk assessment tool and what they can expect?
For sure, Enid. First of all, I'll start off with saying how pleased ISMP Canada is to be working with the research team. We've worked together on other projects before, and it's really terrific getting the human factors and the sort of systems overview input into what we do, and it really expands our thinking, and I think it expands the audience's thinking as well. Currently, the Pan-Canadian Diversion Risk Assessment Tool, it's free. It's open to any Canadian acute care facility. And our goal in this really is to have an interprofessional team from each participating hospital walk through the tool and identify areas in need of improvement. I think it's also important to say we are not expecting any hospital to get 100%. There is not going to be a perfect score on this. Some of the risk items are really sort of hard to accomplish in real life. Some are certainly aspirational. And I think what we do, or what we're going to find when we do an analysis of sort of the submissions, is that there's a number of Canadian hospitals that will get a sort of what we might call a suboptimal score. But we think that's okay because that points out the ways for improvement. And we know that there'll be some items that no Canadian hospitals are doing, and there's going to be valid reasons for that. Some are, significant human resource efforts that require a lot of disciplines to come together. Some are just simply a lack of technology. However, again, these are going to point the way to future improvements that we can adopt as a healthcare system. And as you've heard Patricia particularly speak of the quadruple aim, and I think the assessment tool complements other efforts to improve medication stewardship more generally. Not all medications that go missing are stolen. Some discrepancies are miscounts, there are accidental wasting, there are wrong patient errors. We can learn so much, I think, by better auditing and tracking controlled substances, and then that can be applicable to other processes we have in the hospital, in the facility. We can learn how to order medications more accurately, how better to package them, how better to stock them on wards, how to improve wasting practices, and overall, how to better manage inventory in general. I also want to emphasize that the tool, signing up for an account, also gives you access to the electronic submission tool, introductory material, printed version, and a quick reference guide. It's really not only a tool for assessment, but also a tool for learning and improvement. And in that spirit, we do want to learn from you about how you use the tool and what you think of it. To sign up, follow the link on our website or in the chat box, or submit a request to our email at mssa@ismpcanada.ca. We do require each facility to nominate a lead contact to receive communications, to handle account functions. And your request will be vetted, and you'll receive sign-up instructions in a few days. We do want to ensure that you are indeed a Canadian hospital, and we do want to prevent duplications of results. The process essentially is similar to other ISMP Canada safety self-assessments. So we really want to encourage you to complete the tool and submit your responses. And once submitted, you'll be able to compare your facility, as Mark mentioned, or benchmark your facility against other similar but anonymous Canadian facilities. And importantly, Our research group is going to use the aggregated anonymized data to get a sense of what facilities in Canada are doing with respect to controlled substance diversion. And we're pretty excited about this because, as far as we know, a national snapshot of diversion prevention has never been done anywhere before. So you and your organization will really be contributing to something important.
Wow. Thank you so much, Mike, for the insightful overview of this very important and timely tool. I think, thank you so much for our panelists. I think it may be a good time for us to move on to our Q&A session. It looks like we may have a question coming in.
Yes. Hello again, everyone. I'm back for the Q&A portion of this. We do have a question in the comments, and as we go along, of course, we encourage you to ask your questions. And if we don't get to them, we'll reach out to you after the show to answer your question, or at the next session. So, without further ado, the first question that we have here is from Miriam Moutzi, who says, is there a screening for drug dependence all through job life? And Miriam also adds, for staff handling drugs.
So I'll take a first attempt at answering this question. It's actually quite a complicated one. We didn't put anything specific in the risk assessment tool about drug testing because there's a lot of intricacies associated with it, especially in different provinces, and there's HR and legislative requirements as well. I think in the US, there's been a few papers discussing this. There's just pre-screening drug testing upon hiring. There's also random drug testing, and then there's for-cause drug testing when there's suspicion of diversion. And there have been some authors who've argued against it, actually, because there is a certain false positivity rate associated with it, and does that balance out with the actual detection? I think it's actively debated. It depends on the institution and it depends on the jurisdiction. So I don't know the specifics also of what tests are available. I think some medications are harder to detect. So some people do, there's urine testing, which can be faked, like you can get past that test. There's blood testing, and then there's also been hair follicle analysis because it keeps medication for longer. And the success or accuracy of those tests is variable. I think that's beyond what I know right now, but we could probably find some articles if you're really curious and share them with you.
And I'll follow up on what Mark was saying is that the drug testing has certainly been attempted in various places, but it recognizes it can't be done in isolation. It needs to be part of a program of orientation to how to use controlled substances, coupled with human resource and support for people who may be struggling with substance use or the need to divert medication. So it is, it's a tool. It's a tool, as Mark said, with uncertain benefit, but you need a sort of a large toolbox to address this very complicated issue.
Thank you so much, Mark and Mike. So while we're waiting for further questions, maybe I'll ask for some final comments and suggestions from our panelists. Patricia, any thoughts?
Sure. Maybe I'll just pick up on something that Mike mentioned. Although we talked or we labeled our talk diversion, I think if you apply some of the guidance from the risk assessment tool and the quick reference guide, not only will you be making your systems more resilient to diversion, which is a deliberate act, but you'll also be making it more resilient to other types of drug errors or inventory management issues, because you will be strengthening the systems by which controlled substances are managed throughout your institutions.
Yeah, thank you for that. Very key. System resilience is certainly a very key thing. How about you, Mark? What are your thoughts?
Yeah, I think maybe the point that I would make is that this is a long-term commitment. It's a marathon, not a sprint. So, hospitals that go through the risk assessment tool, it's not one and done. You really do need to have, many of the items involve enduring processes at the hospital where you're consistently looking at your data, responding to it, educating staff. And that can be a challenge for some hospitals. It's might be aspirational, but we think it's well worth the effort. And as Patricia had described in her portion, there's a lot of costs that can be mitigated. And it's also just the right thing to do, as Patricia and Mike have talked about, in terms of, I mean, they are controlled substances, right? So we should maintain as good of control of them as we can. And we're probably missing many incidents of diversion right now.
Yeah, I can't agree more about that. Being on a long-term commitment, I think it's a great way to put it, that it's a marathon, not a sprint. Thank you so much. What about you, Michael?
Well, I'll pick up on the theme of long-term commitment because, you know, this is an area where we really don't understand a lot. We know that happens, but we don't have the insight that we'd really like. So we encourage you as facilities to use the assessment tools, submit your responses so that everyone can learn more. We'd love to begin an analysis of facility responses in July of 2023, which is not that far away. So again, we encourage you to sign up. It's free. Submit your responses, benchmark yourself, compare yourself against other similar facilities. All you really need to do is send us an email or click on the link to get registered, and then you and your team can be on your way to identifying medication process improvements. And as we learn more, everybody else will learn more, because we are committed to sharing, you know, what we learn and what new interventions we can propose or what new interventions others propose. So really, we encourage you to share your experience.
Thank you so much. So many thanks again to our panelists and our viewers who joined us today. Really appreciate the open dialogue on this very important topic, and certainly more to come about healthcare support, healthcare worker support system in future sessions of this series of LinkedIn Live events. So again, stay tuned, more to come. And if any of our viewers have questions after this live session, please feel free to leave your comments as well. And I don't think there's a link below. I think that's the terminology we use.
Yeah.
So as we continue with our path to safety related to medication safety, please mark your calendars for our next session of LinkedIn Live event, Talk with HIROC, on March 9th, 12 to 1 p.m. And we look forward to seeing you there. Thank you for listening.
Yeah, thank you so much for listening, everyone. Like Enid said, the next live stream in the series will be March 9th at 12 noon. If you have any questions or comments about today's show, please send your inquiries to riskmanagement@hiroc.com. Again, thank you so much to our panel for this excellent talk. And thank you to our amazing audience for watching. Until next time, everyone, take care.